Hi friends, today I would like to discuss a few things about Msics Pro, which is giving cosmetically good results. This is a technique where the cornea is ensured to be clear, conjunctiva is quiet, and there is minimal AC reaction post surgery. The eyeball is stabilized with a forceps holding Tenon's fascia delicately with your non-dominant hand, causing without causing any undue stretching. Conjunctiva bleed is avoided by doing a congenital peritomy with a crescent blade. Here I have inserted copious amount of viscoelastics, and then with the help of a cystodome from the side port, a CCC or a continuous curvilinear capsular axis is made. The capsular axis is aided by a good retroillumination, which can be got by just pushing the eyeball towards the nasal side. The congenital pterygotomy, which is done with the crescent blade, and major vessels are avoided, and this helps in keeping the sclera little clear. And then a straight incision is made either in the superior temporal or a superior nasal quadrant, and then a sclerocorneal tunnel is made. This sclerocorneal tunnel ensures that the nucleus quietly comes out through the easy chamber. So now the AC is entered with the keratome. Keratome is entered while going inside, and once this is done, we next step would be be doing is a cortical cleaving iododissection. Cortical cleaving iododissection ensures that the nucleus is freed from the capsular bag and it is prolapsed into the anterior chamber. Once this is done, we can remove the nucleus by the sandwich technique, wherein Vectors and dialer comes into a rescue. The entire procedure is done by instilling 2 drops of proparacaine at the start of the surgery. Here the epinucleus is washed out by just pressing the posterior lip. Care is taken to ensure that the anterior chamber is maintained deep throughout. So if and the cortical wash is then finally done by using the side port incision. The opposite ends of the capsular bag, the anterior lip of the cortex is aspirated out, and finally the subincisional cortex. This requires little expertise and need to be very careful not to touch the posterior capsule. Once the cortex has been aspirated out, the things become quite easy after that. So next step would be to place the intraocular lens. So the intraocular lens IOL has to be placed inside the bag. Now that we have a good view of the capsular margin, we can insert the lens under hydro implantation by keeping the Simcoe inside at the edge of the sclerocorneal tunnel, and then push the lens. The leading aptic goes inside the bag, and then later the trailing aptic is dialed inside. The entire now the IOL is inside the bag, and then the side ports are hydrated, and this is the end of the surgery, and the conjunctiva is closed by just approximating with the forceps. So this is a cosmetically appealing surgery because the patient doesn't have any redness or congestion at the end of the surgery, and he can start using topical medications immediately up on the post-operative day, and the eyes do not need to be patched. This is another case of soft cataract wherein the side port incision is made. There is a good glow, so that is why I'm not staining the capsule. Viscoelastic is injected, and then with just pushing the eyeball, I get a good retroillumination. With based on that, I just do a CCC. CCC is done by just lifting the anterior capsule, having a nick, and then going circularly. So all these steps are done topically, and the patient is not experiencing any pain. The capsular edge is round, central, and it is equidistant from the margins. And now the conjunctiva. Conjunctiva is just peritomy is done by using a crescent blade instead of a scissors. This ensures that the dissection is minimal and the bleeding is less. So the incision is made with the crescent blade itself, and then the sclerocorneal tunnel is made by bringing movements, bevel up and bevel down. The sclerocorneal tunnel ensures that the wound is self-sealing in nature. So this technique involves delicate holding of the globe. The wound is not supposed to be not supposed to be tampered with, and care is taken that so that the wound is not to be touched with the forceps. AC is entered with the keratome, and it is extended at both the sides, and now you can see the excess margin which is round and central. Now just inserting saline by in the form of hydrodissection, which is the cortical cleaving. You can see the nice golden ring, and then it is hydro is done at both the sides, and the one pole is lifted into the anterior chamber. Once the pole is prolapsed into the anterior chamber, the rest of the things, the pavectis can go inside the posterior lip, and then the nucleus is delivered out of the Sinski. So next is the your epinucleus and cortex, which can just be aspirated or just press the posterior lip, and the cortex just comes out. So this is one easy technique where you can give a cosmetically good looking eye, and atraumatic, and it is painless. So finally the cortex is being removed, but starting with the side port incision, the cortex is removed from the edges of the capsular to the edges of the capsular opening, and then finally the subincisional cortex. So this technique ensures that the patient doesn't have any pain, because we are not touching the iris, and we're not letting the anterior chamber collapse at any point of time. So that in that way, the side port incision comes is of a great help. And finally, when you're implanting a lens, you can either do it with a viscoelastic, or you can just use a Simcoe cannula at the edge of the tunnel, and then push the lens inside the bag. First the leading aptic goes inside, and then the trailing aptic. So that is about MSICS Pro, which gives results on par with phaco, and the post-op recovery is good, and the patient doesn't find a difference between two of the techniques. So I would like everyone to start doing MSICS in a topical way and give good results to the patient. Thank you for your attention.